If you have back pain, you are not alone. According to Georgetown University's Health Policy Institute, nearly 65 million Americans report a recent episode of back pain, and 16 million adults, 8% of all adults, experience persistent or chronic back pain and are limited in everyday activities. Dr. Marcus Mazur at Pacific Neuroscience Institute sees people living with back pain and works to find a solution, whether that's through surgery or through some of the many other available options, including medication, physical therapy, chiropractors, and, interestingly, exercises in a swimming pool. In today's episode, Dr. Mazur discusses all the options, when surgery can help, and things you can do to prevent back pain from affecting you in the first place. Hi, welcome to the Think Neuro podcast from Pacific Neuroscience Institute. I'm your host, Dan Faust, and I'm joined today by Dr. Marcus Mazur from PNI. Dr. Mazur, would you like to introduce yourself, please?
Sure. My name is Marcus Mazur. I'm a board-certified neurosurgeon. I joined PNI in the summer of 2025, and I am a predominantly spine-focused neurosurgeon with practice both in Torrance and in Santa Monica. And I specialize in spine deformity, complex spine surgery. I do minimally invasive spine surgery and revision surgery as well as spine tumors.
Great. Well, I'm excited to learn a lot about spine surgery today. It's a topic near to my heart because it's something I've undergone myself. I've had a spinal fusion on 2 discs in 2012, and then another spine surgery to remove a cyst. So I'm sure I'll get a chance to tell my story, but I would love to hear from you about what some of the issues or interesting things you see in modern spine surgery.
Yes. I think, spine surgery in general I think it's a little bit of a challenging topic to understand for a lot of people, just because there's the field of kind of spine care is so vast and encompasses a lot of different types of specialists, ranging from surgeons to non-operative spine physicians to pain management, physical therapists, chiropractors, acupuncture. So the list is quite extensive, and it can be a little bit daunting for people that have back pain or sciatica or worsening symptoms to know kind of where to turn to sometimes. And the treatment options are very extensive, and they range from medications to injections to spine decompressions to fusion operations and kind of large-scale reconstructions. And so, part of my job is to kind of help patients navigate what options may be in their best interest and when spine surgery can be appropriate. And the other thing about spine surgery is that, it's very patient-specific, and, not every patient presents the same way, and individuals that have similar appearing imaging findings on MRI or X-rays or CT scans can have very different treatment options that may be appropriate or not appropriate, kind of depending on their symptoms. And oftentimes spine surgeons may not agree what the best treatment option is as well. And it's acceptable to have sometimes multiple different options for a given patient.
It is something that I found that everybody has an opinion about. Everybody seems to be an expert on what you should do about your back or who you should see. Or
Yes, and I agree. And I do think that there's sometimes a little bit of a bad rap for spine surgery in the media in general. There's a lot of everybody knows somebody who's had a failed spine surgery or had one surgery that went okay and then had to have a revision surgery a couple times or a year or two later. It's a common scenario. Some patients have had multiple surgeries. Some patients had surgery that never helped them, and so discouraged spine surgery for other people. And so I think there's a lot of kind of negative connotation to to spine surgery sometimes, but I do spine surgery as a career and kind of built my professional reputation on it. And so, I like to think that the vast majority of my patients I operate on get better and improve. And so, I do think that there are some misconceptions, but maybe some patients didn't get the right treatment that was appropriate for them.
Well, and I gather that you are also looking at the data and the medical literature and seeing kind of what works and what doesn't work.
Yes, no, there are, significant amount of research on which conditions or which treatment options help which types of patients. And there's good data on like what types of conditions tend to not be effective. For example, in general, in the history, so a lot of patients have undergone kind of fusion operations for back pain or neck pain without having a lot of arm symptoms or leg symptoms associated with it. We know that fusion surgery for back pain is typically generally avoided by most spine surgeons, and so we're trying to exclude patients that kind of get treatment that may not be appropriate kind of eliminates a large portion of kind of dissatisfied patients. And so we do have a good literature that kind of supports that type of, kind of guide treatment options one way or another. But, honestly, like a lot of patients don't necessarily fit into the research studies. And so, it's part of the individual surgeon's job to help negotiate, what the patient's symptoms are, what their imaging is, kind of their goals are, and kind of marry all of these kind of factors into what their best treatment option is moving forward.
And that may be not surgery. You may refer somebody to physical therapy or even to a chiropractor or some other type of specialist.
Yes, I agree. And I think, for the majority of cases, a trial of non-surgical treatment is definitely appropriate. And there are some circumstances where patients have very severe stenosis, or they're losing neurological function, or they have some spinal instability present, where that surgery may be kind of proposed sooner rather than later. But for a lot of kind of chronic degenerative conditions, in general, we encourage patients to trial non-surgical treatments and kind of exhaust non-surgical treatment options with medications, physical therapy, injections, before kind of deciding to go the path of surgery.
I always appreciate it though when I hear that from a surgeon. I can remember when I was going through my own ordeal and people would send me traction devices or other kinds of things, and I was very afraid of doing something that was going to make the problem worse.
Yeah, no, and that's a good point, because oftentimes patients will ask me, well, am I going to make things worse, or should I wear a brace? Should I not do anything? And honestly, that's not kind of practical things, because we ideally with any sort of treatment, you're able to kind of return to normal activity after a period of time, and unless you have some sort of unstable spine condition, there probably a minority of cases where some sort of physical therapy is not recommended, or some treatment would generally be kind of thought of as dangerous. And so I do think the over the door frame kind of traction devices do have their role in certain conditions, particularly with patients with a lot of active compression and pinched nerves. That could be very relieving and then also similar with like inversion tables, it kind of has the similar effect where patients kind of go flip 180 degrees, and it actually kind of decompresses the spine and can alleviate a lot of pain. And so I do think those options do have certain roles in care.
Dr. Mazur noted that people need to be careful in taking advice from online influencers, as not everybody has the same condition, and what worked for one person may not be the right course of action for another. He also said that, while he encourages people to find non-surgical solutions first, surgery can provide a solution in many cases. Here he discusses the ways surgery helps alleviate back pain.
Usually the goals of surgery are to decompress nerves, and so what that means is that oftentimes patients have pain or they have numbness or tingling or weakness because of active compression of the nerves or the spinal cord. And so the primary goal of surgery is to take the pressure off the nerves, whether that is to remove portions of the disc or to remove some arthritis, or to kind of place instrumentation to stabilize the spine. Overall, the goal is to relieve nerve compression. And so that's kind of the overarching goal of spine surgery: alleviate nerve compression, and then if you're undergoing instrumentation to stabilize the spine. And so, nowadays we have kind of a wide variety of surgical techniques that can be performed in order to accomplish this. So it can be accomplished through kind of traditional open surgery or more minimally invasive approaches. And so it really kind of enables, depending on what patient's pathology is and what their individual symptoms are, what had traditionally required maybe a large operation with extended recovery, several days in the hospital, can now be performed more as an outpatient in some cases.
And then would you say is there one that's the most common? I know you talked about the tried and true being the spinal fusion and the rods and screws, and is that still going on quite a bit?
Yeah, so I would say for fusion operations, with placement of instrumentation with rods and screws tends to be the gold standard. This technology has been around for decades and it's still very effective. And it's kind of the workhorse of the spine surgeon's kind of armamentarium. But there are other options with, like, you can do disc replacement surgery, or you can place cages in between disc spaces to help replace the disc height. And there's artificial devices that are motion preserving that for certain patients may be an effective choice. And so there are a lot of kind of different technologies that have been in development that help basically help maybe improve fusion outcomes and can be and allow certain procedures to be performed with less morbidity, less downtime, kind of what we call minimally invasive, less invasive approaches to the spine. And so nowadays, I think well, a lot of patients may be receiving instrumentation with rods and screws, but it's often paired with like placement of a cage, whether it's from the front of the spine, from the side, or from the back, is often kind of where things have kind of evolved at this stage. And so, the technology continues to evolve over time, and so we have a lot of more kind of robotics involved in spine surgery, and there's implants that are kind of customized to patients' individual anatomy, and so the kind of the field is always kind of this advancing towards kind of more specialized care for the individual, not necessarily one procedure fits all type model.
Can you talk a little bit more about those minimally invasive surgeries? Because I know that's something that Pacific Neuroscience Institute has done a lot of work to try to pioneer various techniques to getting tumors, and they're going in through the nose, or they're going in, through the eyebrow, and you can't even see a scar. Is
Sure.
that the same kind of thing you're doing, or where do you
Yes,
do that with the
yes,
spine?
absolutely. So, the concept of minimally invasive surgery is to be able to perform your surgical goals through smaller incisions. And so when you have smaller incisions, there's less muscle disruption. Less muscle disruptions means less pain for the patient and a faster recovery, and ultimately getting back to normal activity sooner rather than later. And so in the world of spine surgery, whereas previously kind of open procedures may have required patients to stay a couple days in the hospital. Now there are kind of more minimally invasive options where surgeons can either use small kind of tubular retractors and get access to the spine in smaller incisions, or they also have there are endoscopic surgery options where even smaller incisions are used to allow surgeons to operate through small corridors. And so it is something that we all of us who do spine surgery here at PNI do an element of minimally invasive spine surgery. It's and then while one thing is that yes, minimally invasive surgery does seem better to the patient and is can be lead to faster recovery. It's also important to know that not necessarily every patient is a candidate for minimally invasive surgery, and there's a large amount of data that shows that whether you do traditional open surgery or let's say surgery through a small tube or surgery through a very small incision through an endoscope, the outcomes tend to be similar among techniques as far as the evidence goes.
Because I imagine one of the challenges for you in a minimally invasive surgery is if you're putting in one of those baskets that you described, or you're putting in a titanium plate to fuse a couple of discs, you need an opening big enough to get that into the body.
Yes, that is true, and that is one of the downsides is that you are somewhat limited by the size of your opening to how large of a device that you can place. And so, if for example, a patient needs spine reconstruction or a large kind of correction of their alignment, oftentimes different procedures would be combined in order to kind of enable the optimal outcome. In certain cases, like approaches can be combined where you do, let's say, like anterior approach going from the front of the spine or from the side of the spine, and then stage it with a approach from the back of the spine. So a potentially large surgery may be split into two separate smaller surgeries over the course of a couple days. And then some surgeons may treat the problem all from the back of the spine and just have one large operation. And again, I think if you break up a large surgery into two smaller surgeries, patients do tend to recover faster, even though they may necessarily be in the hospital around for roughly about the same amount of time. It's just less time under anesthesia over one day, less blood loss, less tissue disruption, and so there are some advantages to that. But as far as spine surgery goes, there are multiple ways to kind of tackle a problem, and a lot of it goes with what your surgeon's comfortable with and what they prefer, and kind of what your individual alignment is or your pathology.
Well, if you're doing if you split it up into two surgeries, how does that work? Are they done on the same day? It sounded like.
Yeah, sometimes again, it kind of depends on the problem. So, for example, you can have a condition called spondylolisthesis where you have slippage of the spine, and what that does is when the spine kind of slips forward. So let's say you have a L4-5 spondylolisthesis, so the L4 vertebrate kind of slips forward relative to L5, and it can compress the nerves that are at that level. And so one thing that can be done is that you can go from either from the side of the spine or the front of the spine. You take the disc out and you place what we call an interbody cage. So it's a device that replaces the disc and kind of restores the height of the disc space. It helps take the pressure off the nerves. And so that's one approach or one procedure. And some surgeons may do that stage of the operation, set everything up, keep the patient in the hospital, and then the following day or 2 days later, go from the back of the spine and place screws in to stabilize it through kind of smaller incisions. And so that would be like a staged operation that takes place over 2 days. Some other surgeons may say, well, we can do this, in the same sitting. And so we do the first stage of the operation and then the second stage of the operation, oftentimes in the same sitting. And it's a little bit longer for the patient, but again, the advantage is that you're even though you're making multiple incisions, multiple approaches, these are much smaller and less tissue disruption than if you did the whole thing through one approach.
Mm-hmm. Yeah, but the one approach you do it and then you're done.
The one, yeah. So that again, so some patients, they say, oh, I'd rather have one incision, do everything from the, just get it done. I don't want to have surgery to divide over 2 days. And so, I just want one anesthetic and that's reasonable too.
by the time they're coming for surgery, they're eager for relief.
Yeah, and oftentimes, patients they're very a lot of patients I meet, and you describe what you think what my opinion would be, what they would benefit from. Oftentimes they say, really, doc, it's whatever you think is best. I'm willing to use your expertise and your knowledge and your experience and to help me decide what's going to help me the most, whether you think that's going to be 2 surgeries or 1 surgery. Really, whatever you think is going to give me the best outcome is what they want.
Great. And did you want to talk about some of the different choices that there are in non-operative spine treatments?
Yes, and yeah, oftentimes we think of non-operative spine care as kind of like a spectrum. And so, the first spectrum is over-the-counter medication. So, do you take Tylenol and do you take NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen, those types of medications? And so that's typically is the first kind of line of care, like maybe activity avoidance, rest, over-the-counter medications. If that doesn't help, then oftentimes patients will have a trial of physical therapy. And physical therapy, typically what I like to get patients involved in, especially if they have lower back pain, is to have physical therapy working on kind of general conditioning, strengthening the core, and strengthening of the other kind of surrounding supporting muscles, their glutes and hips, because a lot of patients with back problems also have weak lower extremity muscles also. And so for some patients that have difficulty even standing or difficulty walking, I would get them into aquatic therapy. And so when patients are in aquatic therapy, and this is different than aerobics, water aerobics, aquatic therapy is with a licensed physical therapist, often in a kind of deep water pool. And when they're in the water, it's like they're buoyant, and so their weight is less out of the equation. So oftentimes they're able to exercise much more effectively in a pool. And so if patients have a hard time just standing or walking, I'll get them into aquatic therapy.
And there are specialists for that.
Yeah, and there's in the Los Angeles region, there's lots of places that have pool therapy, and it's one of those things where patients oftentimes say, "Well, I don't like swimming, I don't like going to the pool," but like it's very effective. It's very a lot of patients that really didn't want to do it, but I encourage them to do it before surgery, and they. It's like a game changer. Like it changed their whole attitude because they're able to exercise with much less pain. And then oftentimes if that, if they don't improve after physical therapy and they have like specific distributions of pain or tingling, then oftentimes the next step would be pain management or targeted injections. And these are epidural steroid injections that's kind of target specific areas where nerves may be compressed or we think where the patients are symptomatic from. And the goal of injections is kind of twofold. And so hopefully it helps alleviate pain and it reduces inflammation, but it's also very diagnostic. So if we do an injection, let's say at L4-5, and the patient's pain is relieved temporarily, but they have, let's say, 80% relief for 2 weeks after the injection, then as a surgeon lets me know that, well, this area that we did the injection is likely to be the pain generator. And then for some patients, well, if you have the injection and it doesn't help at all, then maybe sometimes you have to do a little bit more searching of where the pain is coming from, or we have to try different injection or additional testing.
Dr. Mazur noted that those injections are typically done by specialists, either a physiatrist, a radiologist, or an interventional pain specialist, a physician with specific expertise in doing these types of injections. We should note that when Dr. Mazur talks about L4-5, he's referring to specific discs in the lumbar spine, the lower back. In my own surgery, I had discs fused at C5-6 and C6-7, the discs that sat between those vertebrae and the cervical spine in my neck. Our spines include vertebrae in 5 distinct segments, from top to bottom: the cervical spine, the thoracic spine, the lumbar spine, the sacrum, and the coccyx, or tailbone. Dr. Mazur also referred earlier to stenosis, which will be a common term to many people who've sought help for back pain. Stenosis refers to a narrowing of the passageway inside the vertebrae, sometimes caused by herniated or bulging discs.
Stenosis just means narrowing. And so you can have stenosis, you can have stenosis of your blood vessels, you can have stenosis of your spinal canal, and all that means is narrowing. And so, the thing about spinal stenosis is it typically, if it's causing a problem, it would typically cause oftentimes what we call radicular pain. So this is pain radiating down the arm or down the leg with numbness, tingling, pins and needles type sensations, and can sometimes have specific distributions of weakness in the body. But the thing about spinal stenosis that's kind of interesting is that having some elements of stenosis or arthritis or bulging discs on imaging is very common. In the patient population, they may not be symptomatic. And so, it's the job of the spine surgeon or the specialist to try to marry these patient symptoms with their imaging, because there's very high likelihood the patient's going to have some abnormalities on their MRI that are not symptomatic. And the worst thing that could be done would be to do surgery on a patient that doesn't need surgery by operating on something that isn't causing a problem.
I do remember it was also eye-opening. I had thought that I had arm pain, and I thought I was going to the doctor because I had pain in my arm. And then they went to take the x-ray of my neck. And I said, but the pain is in my arm. And they said, trust us, it's in your neck. And indeed, it was because all the nerves are running, from the brain through the spinal column out into the body, radiating throughout the body.
Every level of the spine kind of corresponds to a different nerve or different distribution of the body. And so, if you have arm pain that radiates down into your thumb and index finger, we oftentimes think of that as like a C6 radiculopathy. If you have pain that just goes to kind of the deltoid area, it's a C5 distribution. If you have pain down your triceps, the back of your hand, is more of a C7 distribution. And so different kind of which nerve is pinched kind of determines which distribution of symptoms can be expected. Now, not everybody's anatomy follows the textbooks, and there's always a little bit variations sometimes. And so you could have, some patients that have, maybe what seems like a C6 radiculopathy may actually have stenosis at the C5 level. And then oftentimes, if we would maybe try an injection, if the injection helps, then again we can narrow it down. But it's also kind of sometimes a little bit surprising when oftentimes when patients have pinched nerves, we expect an element of neck pain or back pain, but there are patients that really only have arm pain that without a lot of neck pain as well.
Another type of non-surgical route that is increasingly available to people living with back pain can be found in the growing field of regenerative medicine, which regenerates, replaces, or engineers cells or tissues to help heal problems. One of the exciting things about regenerative medicine is the way it uses the body's own repair mechanisms to restore normal function. Dr. Mazur talks about positive results people have seen from platelet-rich plasma injections, or PRP, but he cautions that it's still early days, and we can't yet say with certainty how effective such treatments will be for many people. To break down what PRP is, plasma is the liquid portion of the blood, which contains platelets, red blood cells, and white blood cells. The platelets are involved in healing, so in platelet-rich plasma treatments, a patient's own blood is put through a centrifuge where the platelets are concentrated. The idea is that the platelets can then be delivered back to the patient in a way that promotes healing.
There's kind of this growing body of like regenerative medicine, and this would include kind of treatments like stem cell injections or platelet-rich plasma injections, and a lot of kind of more experimental or investigational treatment that has been targeted towards more kind of orthopedic type injuries. And the thing about these types of treatments is that as far as for spine care goes, there hasn't been a lot of high quality evidence to guide which patients would benefit from these types of treatments. And that kind of is the kind of part of medicine that's sometimes difficult to help patients, because a lot of patients will say, well, I don't want surgery. I had a friend have a PRP injection and their back felt great, or, I'm young and, I have a degenerative disc disease, maybe a stem cell treatment would help me. And, the thing about when I tell these patients is that, well, the thing of these treatments is we don't really know which type of patients benefit from these types of treatments. And so, and insurance doesn't pay for a lot of these types of treatments. And so, when I offer patients both surgical or non-surgical options, I like to offer them something that's going to have a high likelihood of benefiting them directly. Whereas with some of these other therapies, while there are certain populations that will benefit from them, we don't really have an excellent idea of exactly which types of treatments benefit which types of pain.
Are those therapies considered experimental, or they've all been through clinical trials and approved by the FDA, I assume?
I'm not aware of specific like stem cell trials or platelet or trials that have or treatments that have FDA approval for the spine. So put it that way. They may have some approvals for other injuries, but for the spine, not for the spine that I'm aware of.
So it's still kind of early days for that.
Yes, it's still kind of in the pre-FDA kind of testing phase. And then there are also other types of treatments for especially for back pain or neck pain, like ablation procedures. There's radio frequency ablation that's been around for decades, and what the thought is that there's a small sensory nerve that supplies what's called the facet joint of the spine. So the facet joint is part of the spine that enables motion, is where arthritis develops. And the idea is that in certain groups of patients, by ablating or using this radio frequency emitter to burn the small sensory nerve, it alleviates joint pain, and for arthritic pain can be effective. And there's also what we call a basovertebral nerve ablation. So this is kind of more targeted towards patients that have discogenic pain or pain from the we thought it is more arising from disc degeneration. And so for these patients, the thought is that there's what's called the basovertebral nerve, which kind of courses along the front of the spine, and the idea is by kind of burning this nerve, it can alleviate a different type of patients with have pain that's coming more from we call it discogenic, or coming from the disc origin. And so this one's a little bit more recent, and there is data that supports it. And I've had patients that have gone this procedure and have benefited from it. I don't do this procedure itself. Again, it's more done by pain management, but for some patient, it is a safer, less invasive alternative to treat what we call axial pain than like a surgical fusion or disc replacement would offer.
Yeah, it's so interesting. I've always heard of ablation used in cardiology and to disrupt electrical signals that might be causing certain heart arrhythmias or something.
Yes. And it's the same idea, is that you can kind of target a specific area, a specific kind of neural network, and disrupt it using a very kind of focal technique. And for a lot of people, it does its job. But thing about ablation procedures is that for whatever reason, sometimes it's not. It's not like everlasting, and so the idea is the durability may be a year, 18 months. But insurance will pay for some of these operation procedures to be done multiple times for patients. And some patients do get significant relief.
One of the other non-surgical treatments that I'd love to hear you talk about, and the word came up a little bit earlier, is chiropractors, because so many people
Yeah.
see chiropractors to alleviate pain, but it's always been, in my understanding, a little controversial as to whether
Yeah.
uh, that
So,
works.
I think if we take a step back for a second. So there's different types of causes of back pain, or neck pain. And so like, you know, what I treat with as a surgeon for back pain is usually because there's spinal instability present. And so, when there's abnormal motion in the spine, that's when you need a spine surgeon, because the surgeon's job is to correct the abnormal motion, and that alleviates pain and gives the spine more durability. Um, but there can also be pain that comes from, like I was talking about, from the facet joints, or the cause arthritic pain. You could have pain that comes from the disc, otherwise called discogenic pain. But you can also have pain that comes from the muscles, and it's referred to as kind of myofascial pain. And so a lot of patients have, back spasms, myofascial pain. The common scenario: somebody's in a car accident, has a whiplash type injury, a high velocity injury, and they develop severe back spasms, muscle spasms. And oftentimes these patients may not have obvious pathology on their MRI. Um, and uh, and when you don't have, let's say, an obvious pathology or fracture, disc disruption, or something clear on the MRI, doctors are kind of limited in what they can offer, And so, and I think a lot of these patients, see chiropractors, because chiropractors do manual manipulation, chiropractic treatment, and adjustments. And so, for these patients, oftentimes they can do myofascial release, or kind of enable by kind of directly applying pressure to the muscles in certain ways to alleviate this kind of tension that's built up. And for a lot of people, it can be very helpful. The thing about chiropractors that is for their kind of studies and their techniques have not been kind of looked at under the same scrutiny in medical journals. And so it's hard to say that there's a standard of care in chiropractic treatment, and if you go to one chiropractor, patient can get the same type of treatment as another, and whether if it's effective or not. And so that's kind of where the controversy lies in, is that, well, we don't really know what they're doing, and we don't know if it's effective or not. And so nowadays for medicine, it's like we want all our treatment to be evidence-based. So you have to have clear evidence of what you're doing to justify the cost, and why you're doing it, and why we're prescribing things to patients. And so, and for chiropractic care, I think it's because it falls under a separate jurisdiction than typical medical boards. So there's really not, from the kind of the medicine side, not a lot of knowledge of what goes on the chiropractic side.
And I imagine it's kind of hard to do a double-blind or placebo-controlled study with anything involving the spine.
It 100%, right? It's number one, it's hard for patients to, be blinded to treatment. And the other thing that kind of was alluding to earlier is that not two patients are the same, right? Everybody's got a slightly different type of symptoms. Not everybody describes their symptoms the same way. Not everybody has the same pathology. And then it's multifactorial. There could be many different causes of pain. They could have muscle spasms. They could have, weak muscles from deconditioning. They could have arthritis. They could have disc degeneration and stenosis and instability. And so it gets very complex.
And so it sounds like when you get a patient when somebody comes to you or gets referred to you, you need to spend a fair amount of time getting to know that patient and figuring out all the different things that might be happening before you can recommend a course of action.
Right. No, I think so. And, you know, I think that a good spine surgeon is able to meet with a patient, examine them, hear their story, their symptoms, go over their imaging and kind of correlate their symptoms to what's going on with the imaging. And so sometimes it's a clear-cut scenario. Patient has, you know, let's say an L5-S1 disc herniation. They've got radiating pain down the back of their leg. They can't stand. They can't straighten their leg. It's you know, and it's clear cut. And you know, this patient, you know, typically you know, would do very well perhaps with a microdiscectomy or surgical intervention, and can be very straightforward. For other patients, it can be quite challenging because you know you know, a lot of patients have back pain, right? And as you get as patients age, back pain becomes more common. And you know, in some patients they respond well to physical therapy. You know, some patients are obese and you know, and they can't walk because it's painful for them to walk. And so, you know, it's in this scenario, you know, I have had a lot of patients that say, well, I can't do physical therapy. I can't exercise. My leg hurts too bad when I stand. And it's a little bit controversial sometimes, but you know, there's a large group of surgeons who say, well, you know, patients have spinal pathology that's surgical, you know, just because they're obese should not exclude them from having surgery, because surgery would help these patients be more active. And I've had plenty of patients that, you know, maybe have a, you know, obesity or high BMIs that maybe some surgeons would say they need to lose weight before surgery. But some of my mentors have said, well, you know, these patients are not necessarily they're going to have a hard time losing weight if they can't have a healthy lifestyle because they're in too much pain. And so so it's okay, I think we're going to getting derailed here a little bit, but it's just one of those things where, like, you know, it really depends on the patient's problems, what their imaging shows, what surgery or treatment could eventually offer them, and whether the results of surgery match what the patient wants. Like, and so, you know, if there are some cases where it's clear cut, and there's some cases where it's not so clear cut. And, you know, in some patients, you know, surgeons would say, well, you know, I really think that you'd get better with non-surgical treatment first. And so I think we should go, you know, physical therapy route, pain management, because surgery probably has a low likelihood of giving you the results that you want. And some patients, unfortunately, are, you know, really sick and have a lot of medical problems and may not do well with surgery. And in some patients, you know, I oftentimes have patients that they have multiple levels involved. They have complete like scoliotic deformity, can't stand up straight, and you know, they're asking me if like a minimally invasive spine surgery is going to help them. And it's like, well, you know, unfortunately, you know, you need a massive reconstruction, but you're not healthy enough to undergo through this procedure. And unfortunately, it's not like something smaller is going to be effective, you know, for your type of problem. And so for some patients, you know, just because a surgery is smaller doesn't necessarily mean it's going to be helpful. And like, I wouldn't want a patient to go through a surgery that's not going to be helpful.
In discussing all the options for treating back pain or spinal stenosis, I couldn't help but think of my own journey. I started feeling pain in my arm when I would play catch with my son, who was 11 years old at the time and was, and still is, crazy about baseball. As Dr. Mazur described, doctors could quickly tell that my nerve pain was related to that narrowing in the cervical vertebrae, which was confirmed by imaging. I told Dr. Mazur about the course my treatment took and some mistakes that I made, and he related that tale to other journeys that he commonly sees in his practice. We tried physical therapy and an injection, and these things seemed to help. And then, unfortunately, in my case, as the problem got better, I didn't really stick with my exercises and my
Mhm.
stretches and all the things that the physical therapist had recommended. And about a year later, you know, was putting a set of golf clubs up on the roof of the car and, felt that pain again. And at
Mm.
that point, they said, you're beyond physical therapy at this point, and now you're kind of locked into this other track
Yes.
to get the surgery.
Yeah. So no. So oftentimes I'll tell patients, let's say you have a ruptured disc. Let's say you have a ruptured disc in the cervical spine. There's kind of two components of pain. So the when you rupture a disc, the body almost treats it like a foreign substance. So the disc is kind of enclosed in a ligamentous structure in the spine, and it doesn't have a good blood supply to the disc. And so when the disc ruptures, the body really treats it as a foreign substance, and there's a huge inflammatory reaction, and that can cause severe pain. It can cause uh, numbness, cause tingling, it can cause weakness, and that's what oftentimes sends patients to the emergency room because the pain is unbearable. And um, the reason why we don't necessarily rush these patients to surgery, and so let's say severe pain, they go to the MRI, they have uh, a disc herniation, and then the doctor kind of refers them to a spine surgeon to see in their clinic. And oftentimes they'll be given like, let's say, oral steroids or pain medication, or muscle relaxants or non NSAIDs, and say, okay, well, once you take this steroid pack for a week, and then take the meloxicam and the Flexeril, and then you'll be able to get in to see your surgeon within a month or something like that. And then oftentimes when patient comes to the office, their symptoms are gone, they're improved, and that's because kind of the inflammation has subsided. And so that's the idea, is that when you rupture a disc, you have this huge kind of inflammatory reaction that flares everything up. Pain's out of control, and then with conservative management, anti-inflammatory medications, physical therapy, the inflammation subsides, and the pain for a lot of people goes away, and they're kind of get back to normal. Now, if you got them another MRI, they're going to have the same nerve being pinched by the disc herniation, but they're no longer symptomatic. And so this patient doesn't need surgery. So this is a case where patient, improve with non-surgical treatment. So, that's the idea scenario. That's why we don't operate on every disc herniation that we see. But then there are some patients that, well, it just doesn't get better or it gets worse over time. Well, let's say, well, initially it was just pain in the neck, and then some pain down my arm. And then after physical therapy, maybe let's say the pain improved in the neck, but then I just can't, this tingling in my arm that's never going away. Anytime I'm cooking or raising my arm, it gets triggered. Or when I drive, I turn my neck and then just get searing pain down my arm, and it's just bothering nonstop. And it's been going on for, let's say, 3 months now. And so this is the patient. Well, we try uh, the oral medications, the physical therapy didn't help. So this is the patient will say, well, let's try this a targeted injection. So let's try the targeted injection, targeting C6. That's where your disc herniation is. See if that gets better. And so let's say the patient gets a targeted C6 injection, is pain-free. Let's say pain-free for the next 3 months. Then we follow them and say, oh, okay, let's see how you're doing. Pain's great. Next visit, okay, great. So let's keep following it. Let's say 6 months after that, pain comes back, and we try another injection. It doesn't get better. And so then let's say it's been a year now. We had a new MRI. The disc herniation's worse. And so this is the patient common scenario. It's like, okay, well, maybe now surgery is more appropriate. You've tried everything. You have this recurrent problem, and then the symptoms went from like episodic to kind of more constant, more severe, more limiting. And so this patient has kind of exhausted non-surgical treatment and oftentimes go to surgery at this point.
And so I'm also interested, my surgery was done by an orthopedic surgeon, and maybe you could talk
Yeah.
a little bit about uh, how does somebody know? Should I see an orthopedist or should I see a neurosurgeon like yourself, somebody at PNO? In my own situation, I was referred to an orthopedic surgeon who performed the spinal fusion that has kept me healthy since 2012. I asked Dr. Mazur if anything might have been different if I had seen a neurosurgeon like him, and how people should make the decision of which type of specialist to see.
So the orthopedic surgeon versus neurosurgeon, 99% of the procedures we perform are interchangeable. Nowadays, like most of the academic societies, the organized spine world is populated by both orthopedic surgeons and neurosurgeons, and so it's from the vast majority of operations, and they are interchangeable, similar outcomes. We do similar work. The difference is in training. So, neurosurgeons spend a large proportion of the residency doing brain surgery, cranial surgery, and we operate on nerves on themselves, and we operate on the spinal cord. So we actually open up the dura, operate on the spinal cord, take tumors out of the spinal cord. And orthopedic surgery does not operate on the spinal cord itself. And so vast majority of patients that have degenerative spine conditions, don't need surgery on the spinal cord itself. But for the kind of the small proportion of the population that has a tumor that's affecting the spinal cord, those would be operated on exclusively by neurosurgeons. And then the training is a little bit different. Orthopedic surgeons, they do, I believe, 4 or 5 years of training of general orthopedic surgery, and then they do 1 year of specialized training in as a spine fellowship. Whereas most neurosurgeons, they do some spine exposure throughout their entire residency, which is 7 years long. And so most neurosurgeons do some element of spine work in their practice, and they train spine throughout the residency. Others like myself, we do an additional 8th year training, and I did my fellowship in spine deformity and kind of complex reconstruction surgery. And so some surgeons do that on top of their neurosurgery training. And so, like, if you look at new grads right out of training, typically neurosurgeons would have more cases under their belt just because of their length of training is longer than orthopedic surgeons. But once you're in practice, we're all colleagues. We all kind of take care of the same patients and bounce ideas off each other.
Oh, nice. What drew you to specialize in spine and to take that 8th year?
There's a wide variety where, some patients require large scale reconstructions. Others you can just do like a minimally invasive decompression, small procedure, same day operation, and they do great. But in general, I like working with patients that kind of try to really improve their quality of life and kind of work the spectrum of ages. Like some of my patients are in kind of like late teens, have scoliosis. Others are in their 90s and sometimes in their hundreds. And so all spectrum. And typically, the goal is to get them back to their normal activity. So get them back to standing better, or walking better, doing things they like to do, improving their quality of life. And so, for me, it's like, it's very satisfying to sit down with the patient, go over their imaging, talk about their problems, and then try to figure out a solution. And if it's surgery, take them through surgery, and then afterwards, very rewarding that that they're improved after, when it's all said and done.
One last question, just interested in if you have any advice for people on how to take care of your spine so that you don't even need to get to that point. In my own journey, I can recall feeling like it was, I mentioned the lack of proper stretching or exercise at that point. But even before that, it was, I worked for several years almost exclusively on a laptop, sitting on a counter stool. And realized that was just terrible ergonomics. And I cringe now every time I go into a coffee shop and see everybody doing that and wondering
Yeah.
what's brewing in their spines.
Well, excellent question. So first thing in Southern California is not as big of a problem with smoking. Like smoking is terrible for, degenerative spine conditions. So stopping or not starting smoking or not picking up smoking, but not smoking is a major thing.
Wow. I'm surprised there's a connection there.
Well, it's not only degenerative for your tissues. In patients that are smokers, they have much higher complication rates and much higher revision rates than non-smokers. So if you require surgery and you are a smoker, your chance of having a complication or an adverse or a poor outcome is significantly higher as well. Other is trying to keep your weight down, avoiding getting obese. That's another major one. Is keeping your weight down, staying active. And by active, I really just mean walking. Being able to stand up straight and walk is a major thing. Another thing is, as patients get older, avoiding osteoporosis as much as possible. And so osteoporosis, osteopenia is very common. Now, if you develop severe osteoporosis where you're developing spine fractures with minimal trauma or unprovoked, you're potentially go down the road of having, a hard time with your back pain and spine problems as you get older. So avoiding osteoporosis is also a big thing.
By eating calcium, by making sure you have enough calcium.
Well, that's part of it, eating calcium and make sure you have magnesium and things like that. But also, once you kind of reach in your 60s, having your bone mineral density checked at your annual visits, and then having your primary care doctor check your bone density periodically. And if you start falling into the osteopenia category, then you may need to get treated, and you may have to go to an endocrinologist to get treatment for it. And so it's one of those things where you want to avoid becoming frail. You want to have a high bone mineral density, which comes along with being active, which comes along with keeping your weight down. And so it's kind of we want to promote wellness, and it's a kind of constellation of symptoms, because once patients kind of become sicker and kind of become more frail, their ability to bounce back from surgeries or injuries is diminished. And so, and then as far as we know, once you kind of reach this frail stage, it's hard to regenerate. And even though this field of regenerative medicine and everything like that, it's really, studies have shown it's very hard to, once you become frail, it's really hard to get out of that frailness. And so the best advice I can give is to avoid becoming frail in the first place as much as possible.
Well, thank you so much. This is terrific. Really learned a lot and really appreciate you being with us, Dr. Mazur. Thank you.
Thanks so much for having me. It's been a delight. And if patients would like to see us at P&I, feel free to reach out to our clinic. We'd be happy to take you on your spine journey.
Wonderful. Thank you.
Take care.
It's encouraging to hear Dr. Mazur talk about all the possible solutions out there for people with back pain. While such pain can often feel debilitating, forcing people out of work or derailing plans, there are many treatments, surgical and otherwise, that can help solve the problem. And Dr. Mazur's thoughts about how to prevent back pain are in many ways a common sense reminder that we need to stay strong, eat right, exercise, and take care of our bodies. This is Dan Faust for the Think Neuro podcast. Thank you for listening, and stay healthy.